Okay, second chapter that you guys are going to do via Moodle narrated lecture is the cardiotonic and inotropic drugs. Again, you're going to be responsible for this information on the upcoming exam. Vocabulary for this chapter: atrial fibrillation, which we've talked quite a bit about, is the quivering of the atria of the heart. The biggest risk there is the development of clots that could pass to brain or lung. Cardiac output is the volume of blood discharged from the left or right ventricle per minute. The digitalis toxicity is the toxic drug effects from administration of digoxin. Heart failure, the heart cannot pump enough blood to meet the demands of the body. We've talked extensively about that one as well. We also call that congestive heart failure, or CHF. Left ventricular dysfunction is backup of fluids before the left ventricle. So left ventricle is not working like it should, so fluid backs up before it, results in shortness of breath and moist cough. Remember, left lung. Neurohormonal activity. In heart failure, it's increased secretion of epinephrine and norepinephrine that results in vasoconstriction, tachycardia, etc. So it worsens heart failure. We do not want this to happen. Positive inotropic activity is the increase in the force of cardiac contraction. So that's a good thing. And then right ventricular dysfunction is fluid backs up before the right ventricle and it results in the peripheral edema and venous congestion. So right ventricle is not pumping like it should. Fluid backs up before that because it's not being processed correctly. And we see that right-sided, quote unquote, heart failure, which is hallmark with peripheral edema. So we're going to talk about the cardiotonic drugs and the inotropic drugs in this section. Those are the two classes we're covering. All right, recap. Heart failure is when the heart cannot pump enough blood to meet the tissue demands of the body. So we commonly call this congestive heart failure. It is a complex clinical syndrome that can result from any number of cardiac or metabolic disorders such as ischemic heart disease, hypertension, hyperthyroidism. Any condition that impairs the ability of the ventricle to pump blood can lead to heart failure, essentially. So we already talked about what left ventricular dysfunction or left-sided heart failure is versus right-sided heart failure or right ventricular function. So if you remember, left-sided heart failure affects the lung. Right-sided heart failure, hallmark sign is peripheral edema, especially of the lower extremities. So another little mnemonic or picture that you can use to kind of picture what these individuals are going to look like. So the left-sided person is definitely respiratory issues. So you'll even see that cyanosis in the extremities, lips, fingers, toes, just because they're not getting enough oxygen. Right-sided heart failure, again, you're going to see that peripheral edema. You also might see ascites, so you might start seeing a collection of fluid in the belly itself, weight gain, all those different things. Okay, you remember this, the RAA system, or RAS, RAAS. So activation of the RAS is caused because of decreased perfusion to the kidneys, and so it activates the system, which essentially raises the blood pressure and adds to the workload of the hearts. So despite what's going on in the body, the kidneys say, hey, I need some more blood here. I need to be perfused, because secondary to the heart, the kidneys, if you remember, are probably the most important organ as far as perfusion, excretion, those types of things go. So the kidneys say, hey, I really need some more blood here. And so it activates the RAS. So it increases the blood pressure and it makes the heart work harder. If all we need to do is perfuse our kidneys better, then this system works great. It does its job. But what if the heart is already overtaxed? Then there is a problem with that RAS kicking in. So we talked a little bit in the vocabulary slide about neurohormonal activity. So in heart failure, the body kind of does a little bit to hurt itself even further, essentially. Whenever things aren't working correctly, the body says, okay, maybe I should give it a little bit more. So it makes more epinephrine and more epinephrine, and that causes vasoconstriction, tachycardia, all of those things that happen in the flight or fight response. Because remember, um, they're the neurotransmitters that activate the sympathetic nervous system. So it actually worsens the heart failure and it reduces the ability of the heart to contract effectively. Over time, what happens is the heart becomes large and boggy. So we have cardiomegaly, which is the enlargement of the heart, and hypertrophy of the muscles. So if we don't intervene soon, a bad thing just gets worse. Okay, so all of those things are happening as heart failure progresses. So now let's look at some other medications. We've talked about medications already that can help in these situations, beta blockers, all diuretics, these types of things. But we can also use some of these other ones. So we have the cardiotonics, which essentially is comprised of digoxin. It's also known as lanoxin. It's the most commonly used cardiotonic drug. Other terms used to identify the cardiotonics, so you might hear these terms thrown around: the cardiac glycosides, digitalis glycosides. So know that digoxin and digitalis are the same thing. All right, no different there. Lanoxin is the brand name. So these medications, or this medication, increases cardiac output through positive inotropic activity. So it slows down the conduction velocity of the AV node. So when the heart is tachycardic, it's just going ba-doop, 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 ba-doop. So this says, hold up, slow down a little bit. Let's decrease the heart rate and let's give an effective pump. So you're getting more bang for your buck, essentially. It's used to treat heart failure and atrial fibrillation. Just as a side note, if any of you grow at home what's known as foxglove, it's popular. My grandma grows it. It's a popular older flower. Another name for foxglove is digitalis, and that is originally what digoxin was made of, out of this flower that we grow in our flower gardens all the time. Of course, now what we are giving is a synthetic medication. They're not producing it from a flower any longer, but just kind of an interesting side note. So digoxin is started with a loading dose, and once we have a therapeutic level, then we'll start with a smaller maintenance dose. Adverse reactions, the big one is headache. They can also feel weakness, drowsiness, and some visual disturbance. Arrhythmia is going to be the most serious complication that you're going to want to watch very closely for, especially if the medication is given IV push. It can actually cause sudden cardiac failure or put into a life-threatening arrhythmia. Contraindications is if they already have digitalis toxicity. We don't want to give them any more digitalis. If somebody is in complete AV block, we do not want to push digitalis. It can cause them to go into, again, cardiac arrest. If patients have an electrolyte imbalance or any kind of heart block, if they've had an MI, a pulmonary disease, kidney disease, or liver failure, we do not want to give digoxin. It's a pretty serious medication. It's used cautiously during pregnancy and lactation, and only when the potential outweighs the harm. So there are other medications that can be used besides digitalis, and if they can switch that person over, they will. Know all of the interactions, and really digoxin interacts with virtually every medication. If you remember thinking back through your slides, digitalis or digoxin given with anything oftentimes caused increased risk for digitalis toxicity. So you want to be very careful in knowing what medications they are already on and how it may affect the digoxin levels. And the list goes on and on. Okay, so that was our digoxin. Now we're moving on, which is a cardiotonic medication. Now we're moving on to the inotropic drugs. So milrinone is an inotropic drug that's used for short-term management of severe heart failure. So it's more of like a rescue medication. So they'll try digitalis or digoxin first. If that doesn't manage the heart failure, then they'll use this medication. The nurse has to continuously monitor the patient's heart rate and blood pressure while they're on this medication nonstop. So we're talking ICU here. If hypotension or low blood pressure occurs, the drug will be discontinued or the rate of administration will reduce. So hypotension is a big risk with the administration of this medication. And again, continuous cardiac monitoring is absolutely necessary because life-threatening arrhythmias may occur. So this is our one medication. It's always given IV. It's digoxin will be tried first, but then this one will be used if severe heart failure cannot be controlled with dig. For both of these medications, pre-administration assessment has to include baseline vital signs. You need to know the apical and radial pulse rate, respiratory rate, and condition. Listen to the lungs. If there's any unusual sounds, you need to let the physician know because pulmonary disorders may rule out using digoxin. Examine the extremities for edema, check for JVD, measure the weight. They may have these issues because remember, we're treating heart failure specifically. You want to inspect the sputum, find out if there is any blood tinged, if it's clear, yellow, tenacious, thin. Look for evidence of other problems such as cyanosis, shortness of breath, if there's dyspnea when laying flat or orthopnea, and if there's any mental status changes that can be related to respiratory. Also with digoxin, if it's being given IV push, and I think I mentioned this in another slide, but I'm going to say it now as well. If you're giving dig IV push and you cannot visually see the heart monitor, another nurse needs to be watching that heart monitor, making sure that they do not go into complete cardiac failure or complete heart failure, cardiac arrest. Again, I know you guys are not going to be pushing medication. It's not within your scope of practice, but you need to understand how dangerous this medication is. So if you are not in an ICU setting where you can visually see the monitor, then another nurse needs to be watching the monitor while you're pushing this medication. It's given very slow IV push, no faster than 1 milligram a minute, and actually slower than that is better. Okay, so we know we've got optimal response to therapy if we get the results that we want. In order to do that, the nurse needs to carefully check the order. You need to verify that you have the correct medication. Digitalization, or when we start someone on digitalis, aka digoxin, may be accomplished by two different methods. There is rapid and gradual. So rapid digitalization is going to have higher risk than gradual, but may be necessary in order to save the patient. So it involves giving loading doses of dig in order to get a therapeutic value more quickly than gradually reaching that therapeutic value. During digitalization, the nurse takes a blood pressure, pulse, and respiratory rate every 2 to 4 hours or as ordered, and certainly with every dose. Periodic ECGs are done. They will continuously be checking serum electrolytes, hepatic and renal function tests will be run, and other laboratory studies, including telemetry monitoring. The patient should always be on continuous cardiac monitoring. Again, like I mentioned before, if given IV, the monitor has to be watched while the medication is pushed. This medication could cause complete cardiac arrest if given too quickly or in some patients that are more sensitive. For parenteral administration, the nurse may give a cardiotonic orally, IV, or IM. So if it's given IV, it's administered slowly. The site will be assessed for redness or infiltration. This could cause some serious issues. If given a cardiotonic drug IM, the nurse should rotate the injection sites. For oral administration, it can be given without regards to The patient may experience weakness, drowsiness, dizziness, especially if they're just started on DIG or if we're doing loading rapid digitalization. You need to make sure that you are ensuring safety. Plan a gradual increase in activities as tolerance increases, and assist with activities and ambulation as necessary. Use bed alarms, put call lights beside the patient, explain that they may be sensitive to the medication. Our number one potential complication with administration of digitalis is toxicity. Observe for signs of digitalis toxicity every 2 to 4 hours during digitalization and one or two times a day while they're on maintenance dose. Labs are drawn immediately before the next dose or 6 to 8 hours after the last, regardless of the route of administration. So whether it's IV or oral, we're going to do frequent laboratory monitoring. Levels greater than 2 nanograms per milliliter are considered toxic. There is a very, very, very small window of therapeutic effect with digitalis. So once we get them to therapeutic level, it's important that we consistently monitor to make sure that they do not become supra or subtherapeutic. Digoxin toxicity can be successfully treated by simply stopping the drug. It does have a short half-life, but if it's severe life-threatening toxicity, if we are seeing life-threatening arrhythmia, then we would administer digoxin immune fab. So that is the antidote to digitalis. The nurse should be alert for the possibility of worsening heart failure, low cardiac output, hypokalemia, or atrial fibrillation after they start giving this medication. The patient and family need to understand that the prescribed drug must be taken exactly as directed by the primary healthcare provider. Oral digoxin is prescribed as a daily regimen, and people will take this medication at home. Show the family how the correct technique for taking a pulse. Know what to do if the pulse is below 60. Tell them that they will not take their medication and need to contact their healthcare provider immediately. Older adults are prone to digitalis toxicity. Remember that renal and liver function decreases. So confusion that occurs with digitalis toxicity may be mistaken for dementia. Do not discontinue the drug without contacting the provider. Avoid taking over-the-counter medications unless they're approved by the provider. That's everything. That's cough syrup. That's everything. Just because there's so many interactions and they may become toxic so quickly. Discuss the possibility of weakness and drowsiness with this medication. Take rest periods during the day and tell them that, as they continue on the medication, their activity tolerance will improve, but it takes time. Know the signs of digitalis toxicity, and I've got them listed on the next page. So confusion is number one, and especially in the elderly, may be written off as, just dementia, or they just got a little bit confused today. But it's going to be something you want to cue in on if they're taking digitalis. They may have an irregular pulse, bradycardia, arrhythmias, especially ventricular tachycardia or ventricular fibrillation. Those would be things that you would want to get them to the emergency room immediately. They may develop an AV block, have a loss of appetite, palpitations. You can read those. Yellow halos around lights are seen. It's called xanthopsia, but basically when they're looking at a light, if they start seeing yellow halo surrounding it, they're going to want to report that to the physician immediately. Decreased urine output or excessive nighttime urination could all be signs and symptoms. Definitely, if we have a low potassium, we are going to be at increased risk for digitalis toxicity. If they're dehydrated, if they're on any number of medications, we could have increased risk of digoxin toxicity. As far as monitoring them, you may be able to see a possible link for toxicity if you see the inverted or depressed ST segment. So you can see it goes down before the T wave instead of following the normal trajectory. So shortened QT interval and a depressed ST segment could be a sign of digoxin toxicity. There is a very narrow window between therapeutic and toxic levels, so you have to be aware of these things and you have to teach your patient about them. So make sure that you study this slide in depth and know what to look for.